like the endothelial cells. Okay, where we will see. Then under that we will get the basement membrane, glomerular basement membrane is a layer of the endothelial cells, and under that we will get the podocytes. Okay, the epithelial cell layer we will get the podocytes. The podocytes basically will be looking like this, like the food processes. Let me show it more clearly. Just like this. Okay, just like the food processes. So we know that basically we'll get here the glomerular tuft, where we'll get, now let's structure from here. Whatever the structure is this, I hope you know this part. This is known as afferent arteriole. And this part is known as efferent arteriole. I'm writing briefly, it stands for the efferent arteriole. Okay. So what's the main function for these regions? The filtration regions. What is the main thing for the filtration regions? So how do the filters? Okay. So whatever the waste products or whatever the nutrients are coming through the circulations through the afferent arterioles, that first they will come here. Okay. After coming here, what they will just pass through the endothelial cells, because within the endothelial cells we see this type of the fenestrated capillaries. There are thousands and thousands of fenestrated capillaries present within the endothelial cells. So this will help to pass the different types of waste products and the nutrients as well. Okay. Then after that we'll see that all the products, all the waste products or the nutrients, they will come through the up to the glomerular basement membrane, and from there we'll get the food-like structures, food processing, that is known as the visceral layer of the epithelium in case of the Bowman's capsule. Okay, and around it will definitely know it. We'll get the parietal cellular layer. Okay, so let me show it here. So we'll get the parietal cellular layer here, and this is the visceral layers. Now there is, you can see there is a gap. Okay, some gaps are here. These gaps are here. These gaps are here. These are known as the diaphragm slits or the pores. Filtrations. We can write it like that. Filtration pore. Okay. Now after coming here, these things will be easily just pass from here to here in this region, then it will come out. And from there we know that the starting of the PCT, and we will get the different types of the epithelial cellular layer shapes. From here it will start the PCT, which is the PCT started from here, the rest of the nephron parts will be there. Okay. Now we need to know what are the problems for, let's suppose for whatever the regions of the glomerular injury. Okay, it may be like but in most of the cases we know that in case of the glomerulopathies, all these things are the immune based. Okay, immune based, but the other regions may be also there. Okay, so it may be like for example, we can see like I'll discuss this part on the letters, like acute kidney injury. We can just talk about the chronic kidney injury. Okay, we'll talk about all these things. This may be also the regions for these things. Okay, now what do we see for whatever the regions, this glomerular basement membrane or the endothelial cellular layer or the podocyte layers are getting damaged. Okay, so whatever the problem we'll see. Before that, I need to just talk a little bit about the physiology of this part. We know that within these layers, with these fenestrated capillaries, these are having the the pores, size of the pores are about to 70 to 100 nanometer, and here we will see the gaps, that is approx 10 to 30 nanometer, 10 to 30 nanometer. Okay, now just see it once that this gap is more greater than this one. Okay, now this pore is small enough that small protein molecule, that is albumin, that is also able to pass through these regions. but why it will not pass in the normal physiological circumstances, that you need to know here. Okay, what's the reason for it? We know that this all the layers we are seeing here, this endothelial cells layer, this globular membrane, all the layers are negatively charged. All these layers are negatively charged. This is also negatively charged, and the podocyte as well. And you know that albumin it's also negatively charged in nature, so it's the negative charge. And the negative will just do the repulsions for each other. Okay, they will see the repulsion in between them. So as a result, this albumin will be not able to pass through these regions. Okay. Now for whatever the cause of the renal injuries or the glomulars, okay, whatever the cause may be there, I will see whatever the problems can be there. Okay. Now I will draw the different diagrams here and try to understand from here. So let's suppose there is a patient who is having the problem, just normally. These things are coming in different, making the glomerular tuft is going to the efferent arteriole, is the afferent arterioles. So we know these parts, that we'll see the glomerular vesicular membrane here. Then we'll see the podocytes. Food processes just like this. Okay. Now let's suppose there is very mild injury. Let's suppose I'm just defining with +1. Okay, as a result we are seeing whatever the problems we are seeing here, that the small molecules like the albumins, they are able to pass through the regions. So whatever the problem we are seeing here, that for the very mild injury, that we know that albumin is the the smaller size, for it is having the chances to pass through these regions. So we'll see in the excretion what is coming out. We'll see the albumin is coming within the urine. Albumin coming within the urine. So only it's especially for these things happens for albumin. So we can say it's non-selective. So it's we can say selective proteinuria. Selective proteinuria. Now, what happened here? Let's suppose for two types of the physiological things we see here, that we just got on the size barrier, where I just said about the 70 to 100 nanometer is the size barrier. Another thing is charge barrier. So for any molecules just to pass through these regions, they should cross these two parts. Okay. So for for the mild injury, let's suppose there are some minimal changes within the charge particles. Though some negative charges are getting neutralized. For examples, they are getting neutralized. So as a result, we will see not all, some part of the charges. So as a result, albumins, there will be some sufficient gap for the albumin to pass through these regions and come out in the urine. Okay. So this will be the normally the selective proteinuria. Now let's suppose there is another person's where we are seeing that is the glomerular tuft. Okay. Now from here, what we are expecting, let's suppose the +2. I'm just is the grade 1 of the +1 injury. It's a little bit severe. Okay. Where we are seeing that this basement membrane is also here, the podocyte is also here. Now, for examples, that these gaps are a little bit larger than this one, so there will be a little bit more injury here. Okay. So as a result, we are seeing within the urine that albumin is also coming, along with the globulin is also able to pass through these regions. Okay. Now here we are seeing the two types of the proteins are able to form within the urine. Okay. Now in these cases, we can say the non-selective proteinuria. Here albumin can be also excreted, along with that globulin is having also chances to get excreted out. Okay. So it's the non-selective proteinuria. Okay. Now let's suppose another person is there. to apply for my drawing and handwriting. If you don't understand, let me know in the comment sections. Okay. There is also glomerular tuft. Here, let's suppose the injury is +3 grade. That means the severe injury. Okay. So what will you see here? This is the basement membrane. Here, let's suppose the size barrier and the charge barrier. Both are not functioning well. Okay. So as a result, we will see is the podocytes loose. So we will see within the urine the heavy proteinuria. Okay, and it may be like 3.5 gram per day. So whenever we will see the severe proteinuria within the urine, 3.5 gram per day. Okay, this type of the problem we will see here. So in the first cases, we see the normal mild injury where only albumin is able to pass. In the second case, we did talk about where the albumin along with the globulin also able to pass within the urine. In the third case, not only albumin and globulin, the other proteins may also pass through these regions. Okay, there may be like the different types of the proteins like the thrombin. I'll talk about this part in letters like ferrotins. The thrombins protein molecules have also chances to pass through these regions, and we can say that near about 3.5 gram per day, the protein losses will be there. Okay. Now the one basic question is here that this 3.5 gram per day protein is coming within the urine. Then we can think about like this thing that in our body, that liver will try to compensate. You will try to compensate by producing the proteins. Okay. Now liver daily around 10 to 12 gram per day. This much protein molecules is produced by the liver every day. Now then, why we are getting 3.5? Then the rest of the proteins where they are gone. So that's the question here. Okay. So what will we see here? Will we see if we see this part here? So these are the proximal convoluted tubular epithelial cells, and these epithelial cells, whenever the proteins will come out, around 10 to 12 through the pinocytosis process. Through the pinocytosis process, the extra amount of the protein that is coming here, that will be taken by these cells, and there will be the catabolization of the proteins, and this severe protein losses will be here. Okay, so protein losses means this protein will be lost within the cells. There will be no using of the proteins. So we'll see 3.5 gram of the protein part will come out. The rest out of 10 to 12, only 3.5 is coming within the urine. The rest will be taken by the proximal convoluted tubular epithelial cells. Okay, by the process of pinocytosis. Then we are seeing the whatever the problem we will see here, the protein losses is too much here. Okay. Then think about this part that whenever the protein loss is too much, then whatever the problem we can see here. So the first type of the problem we'll see. Let's suppose let me draw with another color here. It will be more better for you. Let's suppose the general circulation. Within the general circulations, where we will see what whenever the protein loss is there, we will see hypoproteinuria. We will see hypoproteinuria. So hypoproteinuria, if we see there is a development of the hypoproteinuria here, then whatever the problem we can face. Okay. So when I have hypoproteinemia will be here, so the blood will have the less protein. So this I am just defining with proteins. We have the less proteins. Okay. Now what the protein is responsible for development of the oncotic pressure. Oncotic pressure. Now we'll talk about the hydrostatic pressure, normal physiology part of this one. Then it will be understandable for you. So let me just erase this part here. So normally what we see, let's suppose, let me just erase this part as well. Let's suppose these are the cells. Okay, so from the cells we'll see this, the let's suppose extracellular regions, for example. Okay, so what we see that there are two types of the force will work here. Okay, one is hydrostatic pressure and another is oncotic pressure. So the capillaries. For example, so from the hydrostatic pressure we will see this fluid will come out here, water molecules, and there will be some little amount of the proteins also, water and proteins also. But what will we see here, and there will also supply the various types of the nutrients just to the cells here. Okay, and by the osmotic pressure we will see all the fluids, whatever it is coming out, all these things will be pulled back. All these things will be pulled back within the circulatory systems. Okay, now let's suppose there is a conditions where the protein is coming out, a little bit of the protein is coming out. For a region, hydrostatic pressure is getting increased a little bit, not that much severely. So let's suppose some protein molecules are also coming out, but there is a chances for the protein molecules, they will pass through the lymphatic drainage systems. Let's suppose the protein is coming here. This protein molecules is having the chances to pass through the lymphatic drainage. So the protein will not get accumulated here, so there will be no chances for the development of the edema. Now let's suppose there is another case. Let me show it here once. These are the cells. Extracellular fluids. Okay. Now for any regions, hydrostatic pressure getting increased too much and the oncotic pressure decreased severely. Okay, then whatever the problem we will see that this hydrostatic pressure will just push the water molecules and the other particles, proteins, a little bit amount of the proteins, but here the hydrostatic pressure is increased too much, so the proteins, good amount of the proteins will come out also here. Now the oncotic pressure is less, so it will not the oncotic pressure, as the oncotic pressure is less here, so the fluid retention will be not that much, so the fluid will keep on accumulating here, so that will form the edema. But whatever the proteins are coming here through the lymphatic system or lymphatic drainage, you can say, this will just go to the circulation again. Okay, but let's talk about the third case here. Whatever thing we'll see, these are the cells, something from the circulations or from the capillaries, whatever you can see here. Let's suppose the hydrostatic pressure is normal, oncotic pressure is also normal. Okay, it's a normal. Then hydrostatic pressure is pushing the fluid and some proteins, and the fluids, whatever the fluids, that will be retained by the osmotic pressure to the general circulations. Now whatever the proteins are coming out, let's suppose within the lymphatic drainage there is some blockage, and this blockage within the lymphatic systems can be done by many processes. It can be done by the the cancer cells or for some parasitic parasitics just cause some type of the problem there, or some inflammatory cells. Okay, so as a result we will see there is a blockage of the lymphatic drainage system. So this protein will keep on accumulating here. These proteins will keep on accumulating here. The too much proteins will get accumulated day by day. So whatever the problem we'll see here, this protein will be here. Okay, the fluid will be also, then the protein will, by the the chemosmotic property, it will just attract the water molecules. So in the first case we saw, where here we saw the protein molecules are coming, but the protein molecules are going through the lymphatic drainage. But here we just saw, let's suppose the osmotic pressure a little bit less, sometimes of the the water molecules will keep on accumulating here, so the edema may develop a little bit. Okay, or you can say approx tends to normal here. But in the second case, what did we see here? In the second case, we saw that the osmotic pressure is getting decreased severely and the hydrostatic pressure is getting increased so much. Okay, so as a result, we will see these water molecules will keep on accumulating here. As a result, we will see the edema, and this edema will be severe. Okay, and here we will see the water molecules. Some amount of the water molecules will be here along with the proteins. So in these cases, the edema we are seeing without proteins. The edema without protein. So this type of the edema, if we just, for example,